Dr. Schlicher. Is that correct? Did I pronounce it correct?
Pretty close, Schlicker. So nobody
Schlicher.
gets it exactly right.
All right. Well, thanks for joining us. It's always a pleasure to have a fellow Seattleite on our program here. So we'll just have you start by giving a brief introduction and a little bit about your background.
Well, thank you so much for having me. Look forward to the conversation. I'm clinically an ER doctor, so working in the inner city here in Tacoma, the other part of the town, down from you in Seattle. And so I've worked alongside and with social workers all of my life, and also in the aspect of trying to improve care and appropriate utilization of the ER. So I very much enjoyed the last two conversations about that. But about 8 months ago, I joined Providence to work on two projects as the chief executive of Trusana, which is our behavioral health concierge, working with our social workers to try to help keep our employees supported as well as our patients in our clinics. And then the second piece was working on how we use technology to route patients to the right care and develop asynchronous and virtual care for our patients to meet them where they're at, so that the intersection of all needs doesn't end up in the ER with me for all things when we can't meet them in the health system or the broader social system that is unfortunately far too often failing our patients.
Yes, absolutely. And can you describe a little bit more about how you and Providence are currently leveraging telesocial work to assist primary care and virtual psychiatric programs? And specifically, what does that implementation look like in practice?
There are a number of ways that we are doing it. One is on the inpatient environment, supporting tele-inpatient psychiatry at a number of sites now across the system. I believe over 50 at this point. And Dr. Jones does an amazing job of stewarding that program so that we can bring telepsychiatry to hospitals that otherwise wouldn't have the volume to support hiring an entire psychiatric service. And that increasingly is all too common. And so these patients stay in the ER, they stay in inpatient units waiting for care. And if they could just see a psychiatrist and get their medications adjusted, get into the right therapy, we've been able to show that many are able to go home rather than having to languish waiting for the next level of care. Additionally, we've been able to leverage them, directly with our insured customers to be able to deliver care and counseling. I think most importantly is the care of our caregivers. And that's what Trusana and the behavioral health concierge has been doing, is really working to support those that are providing care in the broader health system. As an ER doctor, unfortunately, I get to see a lot of tragedy in my job, and I see what that does to my colleagues. I remember, a very tragic case of a young girl who was 7 who had unfortunately gotten into her mom's methamphetamine stash and ended up overdosing and came in dead to our ER. And our team worked to resuscitate her and bring her back temporarily, but she ended up succumbing to her disease. But equally as tragic of that was that we lost 2 of our nurses that day. They could not come back to work. They could not see a future for them. And programs like the BHC that work to help our people through those tragedies are all too important, because the things that our people see, the things that they do in all parts of healthcare, are both a blessing and a burden. And if we're not there to walk alongside them and care for them, we lose them, and far too often they lose a piece of themselves in that journey. And so leveraging our technology to meet people in a way that isn't as confrontational sometimes as coming into a specific debriefing session, or having to come to an office where they may feel stigmatized when a colleague sees them, but instead doing it from the privacy of their own home to talk to somebody about their struggles, not just at work, but maybe in their relationship with their kids, with finances. I think it is an amazing gift that we give to our caregivers, and a real piece of support that hopefully helps keep them engaged in the workforce and caring for those that we're charged with caring for at the end of the day.
Yeah, it's amazing work. And you touched on something there in terms of, maybe a lack of full-time social workers being readily available. What are you doing to bridge that gap? And can you give me maybe a successful strategy or initiative that you've put in place to really help kind of overcome that, that lack of maybe just availability of full-time social workers?
Well, I think the next big step we're working on is looking at how to integrate them back into the primary care clinics, and there have been some fits and starts in that. One of the things that we've done that's been successful is reach out directly to the health plans to be able to work with them and deliver care to their members and be able to reach them. And that's something that has grown exponentially over this last year. We've doubled the number of patient contacts a month. Because we're seeing that there's no right route. Connecting via the primary care is great. Connecting through the insurer, it works too if that gets people care in the end of the day. I think the next big evolution is really bringing that full spectrum social work care that addresses the social determinants of health that Dr. Essel touched on just a little bit ago. Is all too important. We are seeing that folks are struggling with food insecurity, as you touched on, but housing, resources, and other barriers to their overall health. And I'll be the first as an ER doc to tell you that 80% of your health is determined by the rest of the things in your life. It's not what we do to you in the ER or in medicine. So the social workers that can help engage in that process can help bring us back to the things that really drive care and really drive the outcomes of your health. Whether it's getting you active in a gym membership, whatever that may be, is all too important if we're going to really, both bend the cost curve of healthcare, but also improve the quality of life for those that we serve.
And then along those same lines, what are the biggest challenges you're facing with integrating these types of telesocial work and support systems and all of these various initiatives you're putting into place? What are the roadblocks and how do you overcome them?
Well, I think with all things in innovation, there's both the technological challenge. Healthcare is complicated, they say, and add technology to that, and it only gets more challenging. So that has been a constant struggle of new challenges of whack-a-mole, of figuring out. I thought we had a stable interface, a new web platform, and there's a new challenge that may arise. So I would say right now, the technology and integration with the complicated health system is probably one of the biggest challenges.
Yeah, we're certainly seeing that kind of across the board. It's, our goal is to improve access and utilize technology, but that creates its own kind of web and difficulties. So my last question for you here is it's a two-parter. Again, thank you so much for your time and for coming in and speaking with us. The HIMSS Care piece came out, and it's all about the promise of AI in clinical care. What are your thoughts on the current state of the AI tools in supporting social work? But more importantly, how can you ensure that, the future of clinical care remains centered around expertise and empathy of the human clinicians while still leveraging the potential of those AI technologies?
It's a great question. It's something I really am passionate about. Before I was a doctor, I was a lawyer, so I also look at things through the lens of risk. And I think there's a lot of promise with AI, but there's also a lot of potential risk. And that's not just from a legal standpoint, but also from a healthcare standpoint to our patients. I think that there's a lot of promise in the summative features and some of the generative features that are out there. I think the big challenge that we have to figure out is where both the responsibility for management and the recognition of the non-cognitive functions that occur in medicine that will maybe not be encoded into it. And a simple example I give is not so much on the A side, but on the virtual side. There was a case that I reviewed where a patient had come in with back pain at the ER, got a CT, did fine, and then went on to 5 subsequent virtual visits where they talked about management and pain and how they were going to deal with it. And the hard thing was that over those 5 visits, not a single person stopped and asked, "Can you walk?" Because in our normal way of thinking as clinicians, I watched you walk into the room. That's already cognitively factored in. And it's not to say it's assumed, but it's assessed.
Mhm.
Well, if you're sitting in front of your computer, you don't know if I can stand up right now. You don't ask me. And so those kind of things that we build into assessment that are not hard coded are not things that you can recognize always. I worry AI is going to miss if we don't teach it to do that properly, because there are a lot of things that we do on a very habitual level in clinical medicine that is not necessarily easily recognized. And so as we build these models, we need to do it in a way that makes and accounts for that kind of thinking. One of the things that I'm working on inside of Providence is a program called MedPearl that is really trying to hard code the clinician's brain and the specialist's brain so that we can take that information, give it to our colleagues in primary care. But as we do that, it's thinking through not just what does the guideline say, but all of the non-cognitive, non-verbalized processes that are going through the specialist's head to help teach our clinicians how to do care safely. And so I think that's the next step is really translating the knowledge and the experience and the habit of medicine and teaching the AI to do it. Great potential, but we got to do it safely and make sure that we crawl before we walk and walk before we run.
Absolutely. Well, we really appreciate your time. And again, thanks for all that you do and all the great work. And hopefully we'll get you back on and have you share some more of your success stories. So thank you again for joining us.
Thanks for having me.